Provider unawareness of serotonin syndrome after methylene blue administration. Methylene blue is a commonly administered intraoperative medication that is used for various clinical indications such as the treatment of methemoglobinemia, vasoplegia, and body fluid labeling. In addition to its clinical therapeutic effects, methylene blue may also have adverse outcomes when combined with other commonly administered agents. Methylene blue is a monoamine oxidase inhibitor, and inhibition of this enzyme results in increased serotonin levels in the nervous system. Other medications that increase levels of serotonin can compound this effect, resulting in patient harm. Examples of medications that can interact with methylene blue include antidepressants, antibiotics, and opiates. Serotonin syndrome is a condition resulting from excess serotonin in the nervous system. This can be a fatal condition, and the diagnosis is entirely clinical and must be differentiated from other diagnoses such as neuroleptic malignant syndrome, malignant hyperthermia, and anticholinergic syndrome. Signs and symptoms of serotonin syndrome can range from mild fever and diaphoresis up to truncal rigidity, which suggests a high risk for progression into respiratory failure. Due to the potentially fatal outcomes of serotonin syndrome, it is imperative for clinicians to understand this medication interaction to allow for prompt recognition and appropriate treatment. Methylene blue has been used as a pharmacologic agent for over 100 years. Despite such a long-standing history with numerous uses, recent studies have implicated methylene blue as a contributing factor in the development of serotonin syndrome. In 2002, the Toxic Exposure Surveillance System of the CDC identified a total of 7,349 cases of serotonin syndrome and found 93 deaths related to its toxic effects. Although the detrimental side effects of serotonin toxicity are generally understood, prompt recognition and treatment may be delayed due to lack of provider awareness. A study conducted in 1999 that explored the effects of antidepressants discovered that 85% of providers surveyed were unaware of serotonin syndrome. In 2011, the FDA issued a public alert regarding the potential lethal drug interaction between methylene blue and serotonergic psychiatric agents. General treatments for serotonin syndrome include discontinuing all serotonergic agents, providing supportive care, and administering serotonin antagonists. With appropriate treatment, serotonin syndrome usually resolves within 24 hours. Dantrolene, the treatment for MH, has not been proven to be efficacious in the treatment of serotonin syndrome. The treatment for neuroleptic malignant syndrome, bromocriptine, a dopamine agonist, may exacerbate serotonin syndrome by further increasing serotonin levels. This is a current patient safety concern requiring further research due to its prominence in the daily clinical practice of anesthesia providers. Given the incidence of cases that exemplified serotonin syndrome after methylene blue administration that were initially undiagnosed or misdiagnosed, it is likely that these cases led to an increased length of stay. This begs the question, does provider unawareness of serotonin syndrome after methylene blue administration result in increased healthcare costs due to delayed diagnosis and unnecessary treatment versus the cost analysis of prompt treatment? We will be performing a standardized cost analysis, which would include a current review of the costs of prompt treatment of serotonin syndrome and a comparison of delayed or misdiagnosis, which likely includes unnecessary CT scans, ICU admission, and other diagnostic costs. We will demonstrate the practicality of implementing a quality improvement initiative aimed at increasing provider awareness of serotonin syndrome to ultimately decrease delayed or mistreatment and the resulting increased healthcare cost. Thank you for this opportunity.